Colleagues, good morning and welcome to this Usher COVID-19 webinar. My name is Linda Ball. I'm a Professor of Public Health at the University of Edinburgh in the Usher Institute. And many of you who are joining us this morning will have joined one of these webinars before. But before I introduce our speakers, I'm just going to run you through the format of the webinar and how it works. And before I do that, just to thank very much our director, Aziz Sheikh, for helping to establish this webinar series, and also the Usher's communications team support each of the webinars. So because you're attending and you've registered via the Zoom link, we won't be able to see the audience. We have other people who are watching live on YouTube. If you have questions as you're listening to our speakers, please do post that via the Q&A panel, which you'll see at the bottom of your screen, not the chat box, which is a separate function. And then what I'll do at the end of the webinar, the 40 minutes or so our speakers will speak for, I'll ask them questions that are being put in the Q&A box. And if you like other people's questions, if you'd like to see them particularly answered, just do the thumbs up, which you can do, sorry. So as I said, the webinar is being recorded and live streamed. You can watch it again, and please do direct colleagues to the live stream subsequently if they haven't been able to join. And also kindly agreed by our speakers that the PDF of the slides will be available on the website. So I'm just going to introduce our two speakers now and hand over to them. So our first speaker is Professor Ewen, who's Professor of Surgery and Data Science and also Director of the Centre for Medical Informatics here at the University of Edinburgh. He's also a consultant HPV surgeon at the Royal Infirmary of Edinburgh. And then we also are going to be hearing from my colleague, Dr. Annemarie Docherty, who's from the Wellcome Clinical Research, who is a Wellcome Clinical Research Career Development Fellow, also in the Usher Institute at the University of Edinburgh, and also importantly, a consultant in critical care. So Ewen is going to speak first and then hand over to Annemarie, and as I say, we'll have questions at the end. So over to you, Ewen. Thank you very much.
Thank you, Linda. I hope you can see and hear me okay. And it's a great pleasure to be able to speak to you all today. In 2012, the International Severe Acute Respiratory and Emerging Infection Consortium had the foresight to establish a sleeping protocol. So this was in the aftermath of SARS, and it was set up ready to be triggered in the event of another pandemic. This project gathers data on patients admitted to hospital in the UK with COVID and includes biological samples for deep phenotyping. As soon as the pandemic hit, a team of research nurses and then students immediately started enrolling patients across the UK. So this has led to one of the richest and most complete data sets of patients admitted to hospital with SARS-CoV-2 and now has more than 90,000 patients within it. So Annemarie Docherty and I today thought we would briefly speak on 5 different areas. We thought it would be useful to look at patient and disease characteristics and how they had changed between wave 1 and wave 2, which we're defining as from the 1st of August. Then we'll talk about some work that we and the broader team have done on stratifying disease severity within hospital. We'll talk about some unpublished work looking at complications and sequelae of COVID-19 in hospital patients. Next, we'll talk about how the hospital mortality rate has changed over time and why that might be. And then finally, we will discuss just some of the difficulties translating evidence, particularly from randomized controlled trials, into practice using some of the steroid data that we have. So this was where we were yesterday? So these are data from Public Health England. Now I've got a really good site that you'll likely have seen at coronavirus.data.gov.uk. So the top plot there is patients admitted to hospital across the 4 UK home nations. And you can see that we're now at about 1,500 patients being admitted each day. That's about 50% of where we were at the peak of wave 1 in the first weeks of April 2020. That translates to 10,000 patients within hospital, 50% of where we were in April. But the number of patients in ventilated beds is less than a third of where we were at the peak. And that represents a likely change in practice, which Annemarie will talk about later. For me, as a surgeon, this week, our general surgery elective cases have now been stopped completely. There are no longer any large joint replacements being done electively, so that is hip and knee replacements. So we are seeing in hospital what we were seeing in the late weeks of March being repeated again. These are ISARIC-4C data. The age and sex distribution of the inpatient population has changed in the patients admitted since the beginning of August. We've gone from being heavily weighted on the left-hand side there to the over 70 age group, who, as everybody knows, had a large mortality associated with hospital admission. But now there are many younger patients being admitted to hospital, patients that are potentially unwell. And in particular, on that right-hand graph, you can see a bulge of female patients between 20 and 40 admitted to hospital. The sex ratio, the number of men compared with the number of women getting COVID or getting SARS-CoV-2 has been of interest and has changed over time. But it is interesting. So the 50 to 69-year-old group and the 70 to 79-year-old group on these plots, which is sex ratio on the y-axis, time on the x-axis, have been heavily biased to men on about a 60 to 40 ratio. But those that are over 80 have always been about 50-50 women, men to women. But that younger age group is now changing now, which was at the beginning of April, again, predominantly men, 60 to 40 in the under 50s, but now is much more equal or even slightly more women to men than before. And Annemarie will talk about that later on. The patterns of comorbidities have changed over time. So this is time on the x-axis and the proportion of patients admitted on the y-axis for different diseases, stratified by sex, and the different lines are different patient age groups. And you can see that asthma and chronic pulmonary disease, COD, COPD, is increasing as would be expected at this time of year. But we know that there was a bulge of patients with dementia, particularly over 70 or over 80 in the first wave, as infections affected nursing homes. There hasn't been much said about it, but we see it again in this second wave. So in that middle plot there, I can maybe point, you can see a bulge of patients with dementia. The dotted line is the 1st of August in the over 80s group. Then the other interesting thing that we're seeing is a rise in the number of patients with malignancy, which we didn't see the first time round. And it's not clear the extent to which that relates to the disruption of cancer services, both surgical and oncological cancer services, over the last 8 months, but it may be related to that. Management has changed over time. This is the proportion of patients being admitted at the top to HDU or ICU, requiring high flow nasal oxygen, those receiving non-invasive ventilation, and those receiving invasive mechanical ventilation at the bottom, stratified by sex, stratified by age, across the duration of the pandemic. And we thought we were seeing less need for respiratory support, but that is not the case, particularly in the female group, where we're now seeing a lot of non-invasive ventilation, higher rates of HDU, ICU admission, and the use of high-flow nasal oxygen, but with a general trend downwards on the use of invasive ventilation. How does that translate to outcomes? So that's everybody on the left-hand side, and since the 1st of August on the right-hand side. Light blue is the distribution of patients by age who died, dark blue those who are still receiving care, and green those who have been discharged from hospital. All patients at the top, those in HDU, ICU in the middle, and those in invasive ventilation at the bottom. So at the top, you can see that the mortality rate has halved since the 1st of August. But at the bottom, those that go into ICU have a very similar mortality rate. And Annemarie will talk about that in detail later. We've done 2 big pieces of work trying to stratify patients by severity in hospital. This is to provide decision support tools to supplement clinical decision-making early in the hospital admission to help identify patients who will potentially benefit from interventions such as greater respiratory support or medications, and also to help guide the level of care that individuals are getting. The first piece of work that we did was a mortality score, a very simple score just using an integer associated with the variables that you can see there: age, sex, number of comorbidities, respiratory rate, peripheral oxygen saturation, Glasgow Coma Scale, urea, and CRP on admission to hospital. So this is in the emergency department, identifying which patients are at greater risk of dying. There was a lot of statistical work done in the background to this, but it was intended to have a very simple, easy to apply score that just required a bit of paper that could be applied when everyone's donned in PPE, that didn't need an app, that didn't need a web site in order to translate patient characteristics into a probability, if you like. The second score, the deterioration model, which is in preprint at the moment, is something in greater depth, which does use an app, which does retain all of the continuous features of the data. So the mortality score works well. It has a good distribution across the population on the left-hand side there. It goes from a score of 0 to a score of 21, with the bulk of the weight of the distribution in the center of that. There is a linear relationship between, or a sigmoid, I guess, relationship between the score and the probability of death, with those with a 0 score having a very low probability of death, and those with a score greater than 19 or 20 having a very high probability of death, and good calibration in a temporal validation cohort using our same data. The deterioration model includes, on top of the variables that are in the mortality score, the lymphocyte count, whether infiltrates are present either in a CT scan or a chest X-ray, and whether the infection has been contracted as an inpatient or within the community. And we've done some work combining these 2 scores or comparing them. So the mortality score is simple. It gives a risk of death at a high level, if you like. The deterioration score uses a more complex model, but it's particularly useful in younger age groups who aren't going to die. And on the right-hand side, the top plot you can see is the probability of deterioration. Deterioration, I should say, is the admission to HDU or ICU, the requirement for non-invasive ventilation or invasive ventilation, or death, so a composite outcome measure. And you can see that in the lower age groups, green on that top plot, it's quite flat. So you can have quite a high risk of deterioration, but maintain a low risk of death, as would be expected. Whereas in higher age groups, the red line there, you can have, it's much more of a 45-degree angle line. Deterioration, unfortunately, in the most elderly is often associated with a transition to death. And the deterioration model has been done by Rishi Gupta and Maddy Nurazdegi, and as I say, is on medRxiv at the moment to look at. We've done quite a lot of work with trying to translate these probabilities into easy to understand messages that I mean, these are not meant to be used for the public. Obviously, the public won't have access to things like urea and CRP, but they should very easily be able to understand the principle by which the score is being applied on. And so there are apps, etc., to help that. There's already been external validation of the mortality score published, but extending it to look at other respiratory infections, so to look at influenza, community-acquired pneumonia, and pneumococcal disease, comparing it to CURB65, CRB65, QSOFA, and NEWS, other scores predicting mortality and deterioration. And it performs very favourably compared with those other scores across the range of respiratory diseases, suggesting it may be useful when applied to patients still at a point when it is not clear whether they are indeed SARS-CoV-2 positive, which is good. And then finally, from me, just some new data that hasn't been published yet about inpatient complications and sequelae. And this is really trying to get to the point around some of the media in patients of working age not dying, and therefore this is not a condition to worry about in the younger age groups, because we do see quite significant complications, albeit in the selected population of younger patients who have been admitted to hospital. So, I mean, as might be expected, the more complications that one has from COVID-19, the greater the probability of death. The Kaplan-Meier plot, simply counting up complications across organ systems, and a really clear relationship, I mean, as would be expected, given multi-organ failure, if you like. But, you know, if you have 4 or 5 complications, then there is a greater than 50% probability across all age groups of being of dying by day 30 of that hospital admission. So this is a plot looking at the rate of any complication stratified by age on the y-axis, stratified by sex, and also by whether the patients died or not. So the blue dots there are for patients that survived, patients that were discharged. But you can see for patients in hospital that, for instance, men in the 18 to 29 year age category had a 50% chance of a complication of COVID-19. And that increased by age in both male and female. And as would be expected, was much higher in those that went on to die. But again, you know, showing that certainly for those that are admitted to hospital, it's not into hospital and then home again after a couple of days. These are really significant hospital admissions. I'm sorry this is a table, but rather than a plot, but this is just to give an idea of the sorts of complications we're describing. So systemic complications such as DVT, coagulopathy, DIC, bacterial sepsis, positive blood cultures, and then acute kidney injury. Cardiovascular includes cardiac arrest, myocarditis, pericarditis, cardiac failure, etc. Neurological includes seizure, meningitis, stroke. Respiratory includes ARDS, bacterial, pneumonia, etc. And again, as you can see in the 18 to 29 or the 30 to 39 age groups, 10 to 12% risk of AKI, 4 to 5% risk of cardiovascular complications, 3 to 4% risk of neurological complications, 35 to 50% risk of respiratory complications, and 40 to 50 or 60% risk of any complication in these young patients. The association between complications and mortality is particularly prominent for respiratory and cardiovascular complications. These are adjusted Cox proportional survival models, adjusting for age, sex, comorbidity, deprivation, looking at relationships between the different complications. And then finally on this one, we have a variable in the data set looking at ability to self-care at discharge. So was it worse, better, or the same as before illness? Now, of course, when someone's been in hospital, of course, if someone's been into HDU or ICU, if this question is asked at the time of discharge, then for a high proportion of them, they're likely to say, yes, I can't do what I was able to do before. And this touches on long COVID, which isn't included in this particular aspect of the data set, as this is the hospital inpatient data set. But stratifying again by sex, proportion on the x-axis of patients who were worse than before the illness, stratified on the y-axis by age and whether they had a complication or whether they didn't have a complication. In the younger age groups, still still a 10 to 15% risk of them being much worse in terms of self-care at the time of discharge, and that goes up to a third of patients in the elderly groups. So this is really trying to extend the work that's been done over the last 6 or 7 months, which is understandably focused on mortality, to really think more broadly as to the impact of this disease, even within the hospital, before we get to discharge. And thank you. I will hand over to Annemarie.
Thanks, Ewan. Thank you, Annemarie.
Lovely. Thank you very much, Ewan. So I would like to talk about the change in hospital mortality over the duration of the pandemic. And I'll just try and, there we go. So if we look at this plot here, and I'll just talk you through it. So we've plotted the week of admission along the x-axis and the proportion of people who were admitted in that week who then died subsequently in hospital within 28 days. And then we've got the rates coming up here on the y-axis. And we've divided it into 3 time points from the declaration of the pandemic by the WHO on the 11th of March through to the beginning of August. So we feel that we've captured that first wave. And what you can see is this consistent and significant fall in the in-hospital fatality from March, where the in-hospital mortality is around about 30 to 35%, and falling down towards the end of July here, where it's only around 10 to 15%. We've divided it into 3 different time points just to help try and explain this. And we've averaged the 4C score for each of those 7-week periods. So interestingly, you can see that the overall 4C score distribution here in yellow doesn't change for patients at presentation to hospital during the course of the pandemic. So it's 11 in March and April, 11 in May and June, and then 10 in June through the beginning of August. But I think it's important to investigate each of the components of the 4C separately. And so looking at potential causes for why we may have such a significant fall in mortality. So just to remind you, the 4C score consists of demographics, so age, comorbidity, and sex, and then the illness severity at presentation. And so that's the respiratory rate, the oxygen saturations, whether the patient has a reduced conscious level, and then markers of kidney function and inflammation. And so looking initially at changes in case mix with age, comorbidity, and sex, we can see that initially we had this large peak of patients between age 50 to 69, which then reduced over the pandemic, and we had a subsequent peak of the over 80s in the middle of May, which we think is consistent with when COVID went into the care homes. We also have a slow but steady increase in younger patients coming into hospital, going from just over 10% to around 20%. When we look at comorbidity count, we can see that this is a relatively frail population, in that over half the population have at least 2 comorbidities, and some of these patients have up to 8 or 9 comorbidities. These +2 comorbidities peak in May, and this again is similar to when the elderly peak occurred. I think we know that comorbidity is associated with increasing age. And when we look at females, so as Ewen was saying, so initially we had this significant peak of men, with a 60% men with only 40% women. But this has evened out towards the end of the first wave with a much more equal 50-50 split. So case mix could account for these differences. So we're having younger patients, potentially with fewer comorbidities and more women in. But when we look at the hospital mortality for each of these age groups, we see that it's falling in each of these. So although, as we would expect, the mortality rates in the over 80s are the highest, starting around 45% and falling down to 15%, it's still falling down, and it's falling down similarly in the younger age groups. Again, when we look at comorbidity, the hospital fatality ratio is falling in all those groups, and similarly for both men and women. So it can't just be the case mix that we have different patients coming into hospital that's explaining this, because within each of those patient groups, the mortality is continuing to fall. So if we then look at the illness severity at presentation, so this is presentation at, or illness severity at presentation to hospital, rather than at ICU admission or at any other part during the hospital stay. But we can see that in March and April, patients had a high respiratory rate. So they came in dyspneic and with a respiratory rate either 20 to 30 or even higher than that sometimes. And that corresponded with the oxygen of patients having a lower oxygen saturation. You could argue that there's also patients are more likely to have been unconscious or with a reduced conscious level, whereas later on their conscious level increased. There was a higher rate of acute kidney injury, and it's not until later on that these patients with a urea less than 7 increase their frequency, suggesting that there's less degrees of acute kidney injury. And when we look at CRP with rates of inflammation, so early on, you've definitely got this hyperinflammatory state in up to 40% of patients who present with a CRP of over 100. And then as the weeks go past, this falls down and patients with a less inflammatory picture come forward. So we've definitely got a different case mix, and I think you could argue that patients at the beginning of the pandemic were much sicker when they first came into hospital. But even so, looking at that again, even within each of these different risk groups, you can see that the case fatality has continued to fall. So if you came in with a respiratory rate of over 30 in March, this was associated with higher in-hospital mortality than it was in July. And similarly for patients who were hypoxic or had acute injury of their kidneys, who had an acute inflammatory state. So we can then look at patients within ICU and look at the amount of respiratory support that these patients have needed. And so I think that this is really interesting, but I am obviously biased, so this is my main background. So there are three common modes of ventilation. So there's supplementary oxygen, which either just through a normal mask or through some high flow nasal cannulae. Then we have non-invasive ventilation, which is a tight mask applied over the nose and mouth and helps or drives an inspiratory pressure into the lungs. And then we have invasive ventilation, where you have a breathing tube which goes down into the trachea and ventilates the lungs from there. And then we also have the combination of non-invasive and invasive ventilation. So non-invasive ventilation is really sort of the new story of COVID-19. So we've never really used non-invasive ventilation for severe acute respiratory infections before COVID came. And actually it came initially to the UK critical care community through Twitter from Italy, where they were talking about their experiences of using CPAP and non-invasive ventilation. And this generated significant discussion within the ICU UK community, whether this could be beneficial, enabling patients to stay awake and avoid being intubated, or whether this was delaying the inevitable intubation and delaying the opportunity to give these patients early lung protective ventilation. And so we were actually making the situation worse. And so the recovery trial has an arm looking at whether early non-invasive ventilation or invasive ventilation are better. And this is ongoing at the moment. But I think what we can see looking at these plots here, so this is non-invasive ventilation. And there has been significant uptake by the UK critical care community in the use of non-invasive ventilation. So starting at around 10 to 20% in early March and April, right up to sort of 50, almost 60% by June and July. So this is very different and not something that we've used before. And I think what's encouraging potentially with that, so there's increase in that, and we've seen a similar fall in patients who are needing invasive ventilation. Now, this may be because patients are less sick and not needing invasive ventilation and are managing to do just with non-invasive, or it may be that we're able to pick these patients out better. This is something that we're investigating at the moment. This box here in the left of both invasive and non-invasive ventilation, I think is what we would call a failure of treatment. So if you start off needing non-invasive and then you go on to needing invasive ventilation, then I think we have failed on non-invasive, and potentially we haven't picked out the right patients to give that non-invasive ventilation to. And you can see this looking at the fatality rates on the other side over here. So patients who get non-invasive ventilation, the mortality rates are on the way down. They're relatively flat, but they're on the way down. Similarly for invasive ventilation, they're similarly flat stroke on the way down. But if you have both invasive and non-invasive ventilation, then your mortality is increasing. And I think that this is possibly because those patients who we think will benefit from non-invasive and then go on to require invasive ventilation are a high-risk group who we are yet to identify the perfect treatment for. The other interesting thing I think on this slide is that the proportion of patients just needing oxygen is increasing over time. So it may be that we have a lower threshold for admitting patients to ICU during the course of the pandemic, and so that is why ICU mortality appears to be falling. And that's something that we are investigating at the moment. So I'd like to go on just to talk about steroids and COVID-19. So reducing the morbidity and mortality of coronavirus requires robust evidence and prompt implementation of effective therapies. And in fact, steroids are our only treatment at the moment which is proven to reduce mortality in patients hospitalized with COVID-19 on oxygen. And this was reported initially by the recovery trial at a press conference on the 16th of June. And then followed up by the REACT meta-analysis published in JAMA, which showed that all steroids, so hydrocortisone, methylprednisolone, prednisolone, and dexamethasone, reduced mortality in patients requiring oxygen. So this is a plot looking at the proportions of patients on oxygen who are adults who are getting steroids in the UK. And so along the x-axis here, we have time. So this starts on the 16th of June when the recovery trial published its, or had its press conference to say that steroids were better for patients in oxygen. And this was accompanied by a letter from the CMO. And then moving forward until the end of September here. And then in yellow, we have patients who did not receive steroids. In green, we have patients who did receive steroids. And in purple, we have patients for who we don't have detail on steroids. And on the left side, we have patients who do not have oxygen. And on the right side, we have patients who did receive oxygen. So what we would ideally like is for this plot on the right-hand side to be completely green and to say that all patients who receive oxygen are being given this cheap and effective treatment, which is readily available in order to try and reduce in-hospital mortality. And you can see that there is, so certainly patients who receive oxygen are given more steroids than patients who do not receive oxygen. And there is an increase, or there's a fall in the patients who are not getting steroids. So there is an increased uptake, but it's not been quick. And in fact, looking in August and September, 25% of patients on oxygen are still not receiving any steroid therapy. I'm just looking a little bit in detail about who these patients might be. So this is looking at the age of the patients. So in pink, we have the younger patients under 70, in green, 70 to 79, and then the over 80s in blue. And you can see that there is a significant proportion of patients in blue, so the 80s, who are not getting steroids despite being on oxygen. So both of these are on oxygen. And if you're over 80, you're less likely to get steroids compared to if you are particularly if you're under 70, but also if you're 70 to 79. And then just looking at the different comorbidities. So again, sorry that this is a table, but there's just a couple of important things I think to pull out. So if you have chronic pulmonary disease or asthma, then actually only 54 to 63% of patients are getting steroids. And for patients admitted with acute respiratory infections, who have pre-existing lung disease, I would say that this is potentially relatively low, and I would expect these numbers to be higher. Patients who have dementia have a significantly lower chance of getting steroids if they're on oxygen compared to patients with other comorbidities. And around 70% of patients who have pre-existing or who are on pre-existing immunosuppressants then go on to have steroids whilst in hospital. And that suggests potentially that this is more of an ongoing steroid therapy rather than steroids particularly given for COVID-19. So I think we have work to do in steroids. If we extrapolate the mortality benefits of low-dose dexamethasone amongst patients requiring oxygen, seen in the recovery trial, so that's one life saved for every 25 treated, then in the ISARIC study, out of the 1,360 patients receiving oxygen but no steroids since the 16th of June, we could have potentially prevented 55 deaths. And then using Public Health England data, if we then look at this in the UK, this could potentially have prevented 158 deaths of inpatients in the UK. So I think we need to continue to drive home the message that steroids are cheap and readily accessible with minimal side effects and may help to reduce mortality in COVID-19. So where do we go next? Well, so our aims are to characterize the second wave. I think as Ewen has drawn out, patients are different, so they're younger, the sexes are more equal, to see who it is that's coming into hospital this time. And to look at other points, particularly reinfection. So there's a few case studies from around the world suggesting that this is possible. So to try and pick this up in our data. And co-infection as well. So patients are likely to come to hospital with influenza and community-acquired pneumonia over the winter, and how does this affect patients who are also admitted with COVID? You know, how do these various severe acute respiratory infections interact? We're going to continue to look at the hospital mortality in more depth, look at how patients with asthma and chronic pulmonary disease behave when they come into hospital. We have some papers ongoing looking at different patient phenotypes by symptoms, so respiratory clusters, abdominal clusters with diarrhea, vomiting, looking at the different passage through hospital and different mortalities. Looking at the cytokine response in the subgroup of 2,500 patients who've had blood samples taken. And similarly looking for genes and genome-wide association screens studies, looking at changes associated with COVID-19. And we've also been able to link to routine healthcare data in both Scotland and in England. So this will enable us to identify the comorbidities of patients with increased granularity and be able to track their trajectories, both pre-admission and follow them up afterwards. So I'd like to stop there. I'd like to just a few acknowledgements, really, just to acknowledge the overwhelming contribution by patients and their relatives who've enabled these 90,000 patients to be recruited so far. And then in addition to them, the over 2,500 NHS research staff and volunteer medical students who managed to collect this data. And we will stop there and take any questions. Thank you very much.
Thank you very much, Annemarie and Ewen. That was really excellent, and we are particularly grateful to you just to pulling all that data together to give us such a good overview and also showing us some of the new findings and also the future planned work. So thank you. We've had a lot of questions. I'll try and group them. I'm going to start with a couple of questions for Ewen, although I think Annemarie, you just touched on one of the questions that was raised. So if we just start with the scores, the mortality and the deterioration scores that you've developed. Question from Ting Shi here around planning to run a clinical trial or a trial looking at the use of these scores. And then also a question for me about the use of these tools in other countries and how you've translated those and collaborated internationally. So we start with you, Ewen. Thanks.
Thank you. So in terms of clinical trials, the scores are currently being explored in terms of whether they should be, to what extent they should inform decisions around treatments. This is obviously a kind of really difficult area. It's one for a kind of national conversation involving lots of different people because it's quite a kind of philosophical question. Do you target rationed treatments to those that are really sickest, or do you try and target them towards those that are going to benefit from them the most? So there's that side of it, which is a really difficult thing to think about. In terms of trials about whether the scores work or not, we are continuing to calibrate the scores on new data coming in. So that's really, as the mortality decreases over time, as Annemarie has shown, then the score will start over predicting the risk of death. I mean, that's just a given. Given that the score is a simple score, then doctors might just kind of recalibrate it in their head, because it's not as if we're saying a score of 10 equals a mortality of kind of 30% or whatever. But it is quite important that we continue to look at the scores over time and continue to provide information as to how well they're performing at this point in time. In terms of other work, we did start off this bit of work with with the intention actually of producing a score that would be applicable in low and middle income countries, and ideally not requiring any blood tests, and particularly not requiring anything like a CT image, which some other scores have used. We ended up including blood markers because we thought that was important, and there was also some questions about whether populations in different countries, some of our own work is in sub-Saharan Africa, where responses to to SARS-CoV-2 do seem to be different, from what people describe. So there are, ISARIC is, we maybe didn't emphasize this enough, but it's an international collaboration. There's data being collected in different countries, and there are now validation studies being performed in a number of different countries, including Colombia most recently, to see how the scores perform in different populations.
Great, thank you. And quite a long question here from David Simon, so I'll just read this out. Either of you might wish to answer this. Have you been able to look at the in-hospital mortality rates over time related to individual hospital site occupancy? So in the early stages of the pandemic in March, hospitals had relatively normal occupancy levels for that time, prior to trying to discharge patients who were safe to do so. Capacity was therefore more likely a problem in March, April, than subsequently, possibly leading to fewer proportions of ITU, HDU admissions for COVID and possibly higher mortality. And this is also likely to vary by hospital region, as disease transmission was very heterogeneous. So I don't know whether you've got any thoughts on that.
So I'll take that. So I think that's a really important question. And I think, there's been a lot in the media recently about concerns, particularly in March and April, that patients were potentially denied treatment from a sort of a rationing point of view. So it's something that we do want to look at, but it's not something that is easy to look at. So the ISARIC study, although we have 90,000 patients, it accounts for around 2/3 of the patients admitted to hospital. So it's not all patients. So it's difficult to then be able to exactly reflect what one hospital is seeing when we don't have all the patients from that hospital. As you mentioned, so different hospitals will have different surges at different times. So we looked at looking at March and April to see whether we could just do that, but actually that might have captured difficulties in capacity in London, but potentially not in the Northwest. So it's something that I think needs to be looked at. Whether we are exactly the right study to do that, or whether we should be looking again with ICNARC, the English Intensive Care Society, and SIGSAG, the Scottish Intensive Care Society, in order to try and identify those further. I think they're important. I think it'll be difficult, but it's certainly something that needs to be done.
Great. To continue with you, Annemarie. Sorry, I'm jumping around a bit, but let's just discuss briefly the main reasons, perhaps from both of you, why you think these patients are not getting steroids, dementia patients, older patients, etc., and what could you do within the system to try and change that?
So that's difficult. So that's work that we've got ongoing at the moment. So there's more investigation that we need to look at. I think when you look at the patients who are on the ward and then in intensive care, with increasing ventilatory support, the higher the proportion of patients who get steroids. So I think if you're very sick, there's a recognition that you need steroids, and that possibly flicks that button and helps remind people. There does seem to be an early signal that more elderly patients or those patients with dementia seem to be getting lower rates of steroids. And that's something I think that we need to investigate further in order to see whether that is the case or whether that's a reflection of something else and is confounding a different relationship. But I think we would definitely support the increased public message that steroids are important and that they're very easy to give, and that they've been the only proven treatment for reducing COVID-19 mortality in patients on hospital and oxygen.
And just very briefly to add to that, are there outcomes for patients who get steroids similar by sex and age group? Question from Lawrence Grover, just briefly if you can.
I will get back to him in a few weeks on that one.
Okay, thank you. So there's a question from Thomas Back here, for you, Ewan. Is there a relationship between the severity of the first manifestation of COVID-19 and longer-term symptoms as far as we can already see them? For example, are long-term symptoms a continuation of a heavier presentation, or can they occur in patients who had only a relatively light first episode?
Yeah, I think the emerging view on that is that complications and what is being called long COVID is related to the severity of disease at presentation. There was a publication from the COVID symptom app out within the last couple of weeks which is obviously some millions of patients, although it is a selective population. But that was suggesting that the number of symptoms described by an individual within the first week of infection related to whether COVID existed or not. I mean, for our inpatient work, what is a what is severity and what is a complication is again almost kind of philosophical. If you have a stroke having had COVID, then you have had severe COVID almost by definition. So it is definitely the case that more severe disease relates to a greater burden of complications.
A really interesting question from Professor Porteous here, potentially for either of you. Can you construct a DALI for COVID survivors? And where would this rank on the list compared to, for example, diabetes or obesity? You might not be able to answer that at the moment. So disability adjusted life year.
Yeah, I suppose people are going to be working on these things for many years, and that feels like something that's going to come out, particularly, across nations. What is the long-term impact of this in terms of DALIs and mortality at population levels? And I think there's still misunderstanding as to excess mortality, and people are still using excess mortality as an argument that COVID is not as bad as is being made out. And I think it'll be interesting to add DALIs also to that argument. What are the long-term consequences for those that don't die?
Okay, I've got a few questions about this. So we've got a couple of questions here about influencing and informing policymakers. So I just want to summarize as a layperson what I think some of the key messages you conveyed are, and then ask you a question about, how you think this study is being used. I think you've already touched on that a little bit. So I think what I'm hearing here is that people who are admitted to hospital now compared to earlier in the pandemic, they're getting into hospital potentially earlier, and their symptoms are not as severe. So you're getting to people earlier in the disease. I think that's the first point you were making, and might that be about testing or whatever. And then the second thing is that the outcomes for patients are better now generally than they were earlier in the year for a whole variety of reasons that you laid out. And then you've also highlighted practice implications for trying to ensure that more patients get steroids. But there's a question here about how you think this study is being used and whether it is influencing both decision making and policy and public debate. I think you've already touched on some of that.
Yeah, so I think that's a good summary. Thank you. Maybe I should have made that one myself. So I think we're very lucky. So the tier 0 of ISARIC, so all this clinical data is funded by the Department of Health and Social Care, and Professor Callum Semple, who's the PI, sits on stage. And so we've been able to share these findings sort of very early, sort of as soon as we see different signals coming through in the data. And then, that along with many other different sources has helped to inform sort of the situation in hospitals across the UK. And so, seeing this steroid signal, is something that we're able to sort of escalate further, and we've got a pipeline for being able to do that.
Great. Okay, I'll try and merge.
Just add briefly, all of the plots that we show are generated daily, dynamically, and available, to SAGE. So they're, all of the data that is collected is made immediately available. And so the work, when obesity was first identified as being a risk factor, that came from us. The nosocomial question came, from us. The changes in mortality over time has changed from us. So a lot of these questions are being asked directly by Chris Whitty and Patrick Valance, and are being able to be answered in real time, if you like. So in terms of the use of the data by policymakers, I think it's a great example of how that can happen.
Of course, and many of us are going onto your website and nicking your charts, and I've been using it in my training for GPs and things, so it's hugely valuable, and I would encourage anybody who's not looked at the website to do that. I'll try and merge two questions. Lawrence, again, another one from Lawrence, but I think this is very broad. He saw that you'd included whether or not infection had been acquired in a hospital in the risk score, Ewen. What difference did this make to the outcome? And then Aileen Keel has said, was it not thought important to include BMI in the mortality score?
Yeah, so Nosocomial infection is associated with about an odds ratio of 1.2 greater chance of deterioration and death. And that's in adjusted analysis, adjusting for comorbidities. They're broad kind of Charlson score type comorbidities rather than really particularly characterising the reason that that patient was in hospital. For the deterioration score, there was a lot of humming and hawing as to whether patients should be, whether nosocomial infection should be something that isn't included in it. But it was thought to be significant enough to justify doing so. In terms of the comorbidities, obesity is included in the comorbidities which are added up, both in both scores. The comorbidities in our hands generally add about the same amount of risk individually. So if you've got cardiovascular disease, respiratory disease, obesity, diabetes, renal failure, all as individual comorbidities all add about 20% to the odds of either death or deterioration.
Okay, great. Mark McLaughlin has joined us from the Times. I am going to ask this question. If you don't feel you can answer it, that's fine. He's asking, do we know how much? So he's pointing out that hospital admissions are almost as high as during the first phase, just in terms of numbers. They are obviously creeping up. We're all aware of that. Do we know how much of that is to do with more care home residents being treated in hospital now rather than not? Very briefly, do you have thoughts on that or not?
So I think, so one of the limitations of ISARIC is that we don't have where the patient resided before they came into hospital. And so that will take some linkage with routine data. And as he says, it's an important question to answer, but it's not something that we've been able to look at directly. I mean, we can certainly say that the sort of the demographic of the first wave was a very elderly population, and the median age was 72. And that of those that died was 80. So I think it'll take more picking apart than just a simple yes/no answer.
Makes sense. And let me ask you about the data linkage studies, Annemarie. You flagged those at the end. Can you give us a little bit more detail about what was planned there? Because we've got a question on that as well.
Yeah, so I think it's the most exciting collaboration I think that I've ever been part of, and it's across the UK. And I think like everyone in all different parts of routine healthcare data, government, everyone has worked really hard to try and get all these different data sets together. And so we have the ISARIC data set, and then in both England and in Scotland, we've got the GP data sets. So it's a primary care, secondary care, prescribing, the test positive data sets, and a number of other data sets and collaborations with ONS, which will really help in order to just delve down deeper into sort of some of these questions that, whilst ISARIC is able to answer questions very quickly, I think this will be able to give a sort of a further depth to our answers.
Great. And I think one more question here. Ros Pollock has asked, are there any further information on the demographics of patients who have both non-invasive or invasive? So I think both non-invasive and invasive ventilation treatment, just broadly.
Yeah, so that's something that we're looking at the moment in order to see if we can identify why those patients have gone from one to the other, and if there's anything obvious, but I don't have any answers at the moment.
Really. So I think I've gone through most of the questions, including, I think, Richard Simpson, if you're listening, I've tried to blend the question about dementia, even though I wasn't asking both your questions specifically. If any colleagues who've asked a question haven't had it answered, I'm sure Annemarie and Ewen would be willing to look at that. And we've heard that Anne-Marie's going to have a think about Lawrence's question. Those questions were quite broad, perhaps not as specific as to what you're used to, but I think there were some very good points made there by those attending. Again, that was fantastic, and we're really, really grateful to both of you. Also, just a personal note from me, from the Usher, thank you for everything that both of you are doing. It's so important, and we wish you all the very best with the rest of your work. So thank you. I'm going to say a few words now about the next webinar. So I'm really delighted that we have confirmed the next webinar from Uruguay. Now, the reason why I was particularly keen that we hear from Uruguay next is if you've followed any of the data from our World in Data or the other data sets, you'll see that Uruguay is a striking outlier in Latin America in terms of its ability to deal with the pandemic. A country that has a strong public health infrastructure and a long history of being an international leader in public health. So we have a really outstanding speaker actually who's going to come and join us and be at the forefront of both advising government and public communication around COVID-19 in Uruguay, also in Argentina and other neighboring countries. So this is November the 17th at 2 p.m. Do join us. Henry's going to present pre-recorded slides in Spanish. We're then going to have them translated, and then Henry will obviously be joining us and we'll be having some translation there available on the day. So it should be a fascinating webinar. We are planning ahead for at least 2 more before the end of the year, and we'll keep you posted on that. So final word, just to sincerely thank Annemarie and Ewen again for their excellent presentation, and to all of you who registered and joined us on Zoom, and to everybody else who's taking the advantage to listen on YouTube. So please do share the link subsequently. Thank you very much.